Hi, this is Dr. Masters. We're going to do a quick review of the basic principles of pharmacology. Within this, I'm going to add some additional information that you can apply for your future practice. We're going to cover the pharmacodynamics, which is the drug-receptor interaction, drug-receptor activity, dose-response relationship, drug potency and efficacy, pharmacokinetics, absorption, distribution, metabolism, and elimination. Pharmacodynamics, this is the effect of the drugs on the body. So this is what you see happening to your patient. You give a medication, the patient's fever goes down. That is pharmacodynamics. Pharmacokinetics is what's happening inside the patient. You give the patient an antipyretic such as ibuprofen. It is absorbed. It is swallowed through the GI tract orally, absorbed in the small intestines, moves through the body, distributed, metabolized greatly through the liver, and excreted through the kidneys. Most drugs work by binding to receptors. How I like to think about drug-receptor interactions is on all the cell surface, there are literally parking places, for lack of better terms. So think of them like a pinwheel. And once the receptors are full, meaning a drug's receptor is parked in there, then no more drug can fit in there. So the drug molecule must fit into the receptor. So it's a lock and key mechanism, so it has to be basically matching is what that is saying. So back to the parking lot kind of description. So if you have this pinwheel or this wheel looking format, and they can all park all the way around it. If there is no parking spot available, you have free cars roaming looking for a parking spot. We're going to come back to what those free cars really mean and what kind of damage that they can cause in a little bit. But when they're all full, they have nowhere to park. But when there is a free spot, they just kind of pull in and park there on the cell surface. Drug receptor binding, it is reversible, it is selective, and it is graded. So basically the more cars or the more receptors that are binded together with that drug, the greater the pharmacological response. Now, so if you take enough of a medication that you fill up every receptor on those cell surfaces, you're going to have obviously a greater response. You take a small amount, you have a less response. We'll just use ibuprofen again. 200 milligrams versus 800 milligrams, you're going to have a greater response. So drugs that bind to receptors may be agonist, partial agonist, or antagonist. Know the meanings of those words. How drug dose is determined: dose-response relationship, therapeutic index, plasma level profile, half-life, and bioavailability. We're going to talk about all of these. Drug-dose relationship. Dose-response curve depicts the relationship or the relation between drug dose and the magnitude of the effect. Doses below the curve do not produce a pharmacological response. Doses above the curve do not produce much additional pharmacological response, and they may have unwanted effects, toxicity. You will see this when you look up medications, and it will say, for example, in inhalation steroid, it will say, can give X amount to X amount. Doses greater than X have not seen much more improvement than X. This can happen on straight oral, not just inhalation, but oral medications as well. In fact, the risk for toxicity just goes up. Why? because you've used all the cell receptors, because you've given great amount of the drug. The drug has parked in all the receptors, and now there are cars or drugs floating around freely, and they've got nowhere to go. The more free you have, the greater the risk you have for toxicity. If it's not in a receptor, there's a problem. And sometimes if it's in a receptor, you have a greater pharmacological response than you wanted as well. So it just depends. Free drug, you have unwanted effects, and then, you know, even parked in a receptor, you can have, if it's too much, you can have unwanted effects. Just too much drug is too much drug. Plasma level profile. This is the onset of action, the time between you gave the drug and the first sign of the drug's effect. Ibuprofen, again, good example, 45 minutes you should see something, an hour and a half you should see the peak of its effect, the maximum concentration of the drug in the blood, the point at which the drug is being absorbed and distribution is equal to the amount being metabolized and excreted. Duration of action, continued entry of the drug into the body with levels above minimum effective concentration. And we'll talk about MEC in a little bit. And then termination of action. Now here's where we're going to talk about some of these pharmacology terms. Half-life, the amount of time in which drug concentrations decreases by 50%. It usually takes 4 to 5.5 lives to get a steady state blood levels. And it takes 4 to 5.5 lives to totally eliminate a drug from the body. Just the same, mirrored effect. Area under the curve, AUC, the average amount of a drug in the blood after a dose is given. Forgive the spelling errors on here. It is a measure of the availability, the bioavailability of a drug after it is administered. The MIC, the minimum inhibitory concentration, the lowest concentration of an antibiotic that will inhibit the growth of organisms after overnight incubation. So this means the minimum antibiotic that will essentially work. So a lot of times on culture and sensitivity reports that you'll see when you get back, it'll say less than X, or less than, you know, this number is going to work, greater than this is not, and it'll go by R, which means it's resistant, I, indeterminate, and then S, susceptible, and there will be a number out beside it. So, and I believe on most urine cultures, 30, if it's greater than 32, they just say no, and if it's less than 32, you know, it's a go. You can go with it, but always go with the letter saying it's susceptible, because sometimes even if it's less, I've seen it come back and say it's a 16, but it's not considered acceptable, and for whatever reason, this particular bacteria is not acceptable to use with this medication at this MIC, and it's just not. So maximum concentration, the highest concentration of a drug after a dose, and trough, the lowest concentration of a drug after a dose. Those that have given or administered vancomycin should be very comfortable with peaks and troughs, but this is going to be applying things to the outpatient world, something you must really understand. Minimum effective and minimum toxic concentration. So minimum effective concentration is the level below which therapeutic effects will not occur. Minimum toxic concentration, level above which toxic effects begin. So the therapeutic index or range is somewhere between those two things. So your hot spot is really within that therapeutic index or range. Most drugs have a wide therapeutic index, but there are some that have a narrow therapeutic index, and we'll talk about those. Drug bioavailability, the percentage of a drug that is absorbed and available to reach the target tissues. By definition, when a medication is administered IV, its bioavailability is 100%, because it did not have to go through the GI tract. It went straight to the target tissues. When a medication is administered via other routes, via orally, its bioavailability decreases due to incomplete absorption and first-pass metabolism. And we'll talk more about first-pass metabolism in a little bit. Here we are. So first-pass effect or first-pass metabolism, hepatic metabolism, all oral drugs go through this before they can be used in the body. After being ingested, the medication is absorbed through the small intestine and then enters the portal circulation. Once it's inside the liver, the CYP450 or the cytochrome 450 system is responsible for the metabolism of many drugs and many other substances. This can be herbs, this can be grapefruit juice, that could be so many things. If it goes through first pass hepatic metabolism, which a lot of things do through the liver, in fact, we don't give the liver enough credit, and we're kind of mean to it sometimes. Alcohol, including, goes through this first pass metabolism. If it has an extensive first pass effect, it can't be given orally. For example, we found insulin can't be given orally. Therefore, it goes through subcutaneous route or intravenous route, depending on the situation. The CYP450 system is the most active in metabolism. There are other forms or areas that metabolism occurs in the kidneys, in the GI tract. There's bacteria in the gut that breaks down drugs, and then in the lungs, carbon dioxide also can break down drugs. Absorption, it's the bottom line definition is the movement of the drug from its site of administration into the blood. So that's why the bioavailability of an IV medication or a drug injected directly into the vein, into the bloodstream, is 100%, because it is absorbed right away into the blood. So the absorption, movement of a drug from its site of administration into the blood. So if it goes into the GI tract through the mouth, and then down the esophagus, through the stomach, and then it goes to the small intestines where it's most of the time absorbs, and then into the portal vein through the first pass effect. Then you're talking, there could be some great loss if it has a large first pass effect. So variables that influence this absorption, the nature of the cell membrane, blood flow at the site of administration, so solubility of the drug. So we talk about phase 1 and phase 2 of metabolism soon. More water solubility of the drug, greater absorption of the drug. pH, and that's referring to the gastric pH, molecular weight, drug concentration, and dosage form. Also, distribution, definition, it's the movement of an absorbed drug in bodily fluids throughout the body to the target tissues. So this is, once it gets in the blood, is it distributing properly? Where is it going? Is it getting to where it needs to be? Distribution requires an adequate blood supply. So if you have someone really, really sick or have a low blood count, then you can give them all the medication you want, but if you don't first have a good working body, this is not going to be very helpful. So drug distributed to areas of high blood flow first. So I will often tell patients, if I'm treating something on an extremity, for example, I'll say, that's a really bad cellulitis on your foot, on your lower leg, on your finger, on your hand. I really need you to elevate that. I need you to do warm compresses, anywhere from 10 to 20, 30 minutes, whatever. And then right after, or as you're doing this, take the medication or time it somehow with the timing of this drug, so that I know that that antibiotic is going to go toward, I'm increasing the blood flow to this area, and then I'm having them take the medication or whatnot, like take the medication and then increase that blood flow to that area. And that is going to have a much better outcome than if you leave that extremity in a dependent position that's already edematous and not getting good, venous backflow back up, or it's just not getting the blood flow that it needs. Or if someone's got really cold hands and it's just not going to work out for them to have really good flow back and forth to get it healed, because it goes to areas of low blood flow last. In circulation, protein binding is very important. Drugs are bound to protein. So some of the drug is not bound. Some of the drug is not bound and is called the free drug. So this is the free drug that we were talking. And free drug plus bound drug equals a drug protein complex. It's very dynamic. Free drug is an active drug. So if the drug is not bound to protein, it can still be very active in the body. And so that's where we kind of get a little nervous that if someone has, say, an albumin of 2.4, and we give them a very highly protein-bound drug, they're probably going to have some toxicity, because it's free in the body. It's gonna do whatever it wants to do. It's not gonna go where we want it to go. You're giving someone who's probably pretty sick with a low albumin, or at least a very poor diet, a very highly protein-bound drug. And if you gave it to them in a high dose, you weren't careful, you just kind of need to know. So as a nurse practitioner, you're going to have to know, hey, is this person eating well? Because depending on your setting that you're working in, you may not be able to draw an albumin and then be able to give them the medication. They may come in with something that needs to be treated right away. You may have to just ask these questions and say, look, I need you to eat really healthy the next whatever while you're taking this medication, and just dose the drug appropriately. It's not the time to go all out on giving them the highest dose of the drug when you don't know certain things about your individual patient. Pharmacology is very dynamic, and you can hurt patients if you are not careful. There's a lot of unknowns, kidney function, for example, and a lot of things are liver function, and all of these things are things that need to be taken into account when you are dosing patients. And dosing is a large part of what you do. It's not just drug selection, and it's also should you treat and how should you treat, pharmacologically, non-pharmacologically. All of these things must be considered. Degree of drug binding. Drugs exist in bound and unbound states. Bound to protein. They travel when they're bound, and they cross membranes when they're unbound. Highly protein bound, ratio of bound drug usually remains stable. Low plasma protein, and that's low albumin spelled wrong, will result in more free drug in circulation and the possibility of the toxicity that we talked about. Competition for protein binding sites. Finite number of plasma proteins, they compete and displace each other. More free drug, and there's a higher risk for toxicity. So if you're giving a lot of medications to an individual, and they're all very high protein binding drugs, they're going to be fighting for those spaces, and you're not going to know which one could be causing a particular problem for a patient, because we don't know what's exactly happening in the body pharmacokinetically. We just know where the patient is experiencing. So you've got to really listen to the patient. And it's not always the drug's problem. It could be something we're just overlooking and blaming on the drug. So you really have to listen to your patients. And more drug may be eliminated than what we really wanted because, again, there's interactions at play here as well. The narrow therapeutic index that we're coming back to. Drugs with a narrow therapeutic index, these are the most well-known, and you should know these. Drugs with a narrow therapeutic index is warfarin. You need to monitor the INR, digoxin. You monitor the digoxin level, EKG, and electrolytes. Now, I noticed that a lot of people that come into the program don't really understand labs very well. So if you're one of those that really don't understand what's the difference between a BNP or a CMP, a BNP is a basic metabolic panel. It's going to basically give you your electrolytes and your kidney function. That's it. And your electrolytes are limited. It does not give you a magnesium or a phosphorus or anything like that. It's going to give you just sodium, potassium, calcium, and very, very, very basic stuff in your kidney function. And then your complete metabolic panel includes your liver function study with it, or your liver function test with it, and there's no difference. So when you're monitoring electrolytes for digoxin, you have to do the BMP, which has the potassium and the calcium in it, which is what this is interested in order the magnesium separately. Now, theophylline, you just monitor the blood levels, and whenever it says monitor the blood level, it's a theophylline test. You order it. Theophylline is used in the treatment of asthma, and it's not used very often, although I still see some patients on it. I think I just have one on it right now that I see pretty regularly, but it's very uncommon to see someone on theophylline. And then Tegretol and Dilantin, again, there are specific studies or specific lab tests to measure those blood levels. And then with levothyroxine, you monitor a TSH, and with lithium, you monitor a lithium level and monitor a TSH because they are at risk for hypothyroidism. Tissue distribution. Lipid-soluble fats have a high affinity for fatty tissue. So, and that's adipose tissue. Adipose tissue has low blood flow. So bone, some drugs have an affinity for bone. For example, tetracyclines like to deposit in the bones and teeth. The blood-brain barrier. The blood-brain barrier is relatively impenetrable, usually protective, and only lipid-soluble drugs cross the barrier. Placental barrier, many drugs pass this barrier, and low molecular weight drugs pass easier. Metabolism, also known as biotransformation, chemical change. There are lots of ways to explain metabolism, but it enhances the excretion of the drug, inactivate the drug, increases the therapeutic action, it activates a prodrug, and it can increase or decrease toxicity of the drug. Factors that influence metabolism: age, genetically determined differences. So everyone could just be born differently through just how your genetics can influence how you metabolize drugs. For example, I believe your book gives a pretty good example, and it states, I believe it says something about 7% of Caucasians with the CYP, was it 2D6 or 2C9, do not convert hydrocodone to morphine. So, I mean, that's a pretty big, That's a pretty big number. And so if you're not converting it, what's happening? Well, you just have no therapeutic effect to it. And so we probably are labeling a lot of people as drug seekers when really they're not converting it, or they're just maybe very rapid metabolizers of it, if that's their genetic predetermined difference. If they're just, very fast metabolizers. And it just goes because there's hypermetabolism and there's hypometabolism of drugs, and then there's just normometabolism. So there's all kinds of genetic variants of this. But I did hear of a pain doctor that was using genetic testing to test for this difference in patients, because it's also very prevalent in Asian populations. As well as using genetic testing to look for the genes associated with addiction. So he appeared to be very resourceful in using this, and patients, of course, had to sign that they would undergo this form of testing. But again, pregnancy influences metabolism, liver disease influences metabolism, time of day, environment, diet, as we talked about, albumin if it's protein bound, alcohol, and then drug interactions. Other medications influence metabolism. Factors that influence metabolism continue. Drugs undergo one or both of two types of chemical reactions in the liver. So basically, this is saying that, you're going to have you're going to get phase 1 or phase 1 and phase 2 of metabolism in the liver. Phase 1, oxidation, hydrolysis, or reduction to increase water solubility of drug molecules. The end goal here is we're trying to make it more water soluble. Phase 2, again, if it's not water soluble enough, it'll go through conjugation or union of a drug molecule with a water soluble substance to help it further get to where it needs to be. Kidneys excrete it better when it's in a water soluble status. Again, phase 1 enzymes, the cytochrome P450, this is it when it happens. So when you're talking about metabolism and you're talking about the cytochrome 450 system, it happens during phase 1. The majority of medications are metabolized in the liver by hepatic isoenzymes, and these isoenzymes are the CYP450 system. And the most common ones are 1A2, 2C9, 2C19, 2D6, 3A4, and you can see them here. It would be expressed as CYP or CYP 1A2, CYP or CYP 2C9. That is how it is expressed. There are developmental differences in the isoenzymes, and there are genetic differences in the isoenzymes. Some disease states alter isoenzyme activity. For example, cystic fibrosis has altered CYP2D9 activity. Now, when it talks about genetic differences in the isoenzymes, that can be what's called a SNP, and that is SNP. S is in Sam, N is in Nancy, and P is in Paul. A SNP would look like CYP2D9, and it would have an asterisk on the end of it, and then a number. So it'd be like CYP2D9 asterisk 1. That would identify it as the first genetically altered or mutated version of that isoenzyme that was found. There is a difference between SNPs and just the normal isoenzymes. You need to know the difference between these. The difference is the ones with the asterisks are genetically mutated. The other ones are just normal, genetically handed down. So the difference is one has been mutated and one has not. One is more predictable and the other one is not. But as we learn and identify it, it can be more predictable. Now, the enzymes may be slowed, which is inhibited or increased. A lot of people have a hard time with this concept, and it says we call it inhibitors or inducers. So what that means is if you pair a substrate, which is any medication or substance, with an inhibitor. So if you pair any medication, if you pair medication A, substrate, with an inhibitor, medication B, it is going to inhibit the metabolism of medication A, and then medication A, it will not metabolize out very fast. It slows it down and it can build up in the body and cause a toxic effect. Then you have inducers, which again, you have a substrate or medication A, and then you have medication B, the inducer, and the inducer speeds up metabolism. So then it is so, medication B is so quickly metabolized out of the body, it has therapeutic failure. So you really need to understand this concept. Potent inhibitors. So this is considered problematic drugs, classes, or substances. They're responsible for a large number of drug interactions, and they slow down drug clearance because they're inhibitors. So they slow it down. And those are the ones listed here on this slide. Know these. If you see them, you should say, oh, this other drug is being given with one of these drugs or these substances. That means it could lead to toxicity or any side effect associated. So macrolides cause QT prolonging. So if you give macrolide with another drug that causes QT prolonging or something else, it's going to slow down the drug clearance and build up toxic effects. So it's going to slow it down, and therefore the drug is going to build up and not clear very well out of the body. If azithromycin is already a 5-day drug pack that has a 72-hour half-life, and you slow it down even more, that is not good news, guys. Prodrug metabolism. A prodrug is a drug that when you administer it in an inactive form or significantly less active form, or it is administered in an inactive form, excuse me. Once it's administered, it's metabolized in the body and it becomes an active compound. There is a Parkinson's drug. I think it's Cinnamint, if I'm not mistaken. I believe that is the one I'm thinking of. That is a prodrug. Elimination, this is excretion. It's removal of the drug from the body by the organs of elimination. And that can be, lungs, GI tract, sweat, saliva, breast milk, but most often it's the kidneys. The renal elimination is passive glomerular filtration, active tubular secretion, and tubular reabsorption. Glomerular filtration, the availability of the drug for glomerular filtration. Drug must be unbound from protein, because remember, when we find protein in the urine, that's not good, because protein is a larger molecule, and when we find it in the urine, that's how we know microalbuminuria. When we see that in someone's urine, we know that something's wrong with their kidneys, or they have uncontrolled hypertension, uncontrolled diabetes. Their kidneys are hurting somehow. So it's typically only excreted when it's unbound from those proteins, because proteins are too big to go through this system. That's how I like to think about that. So free, unbound, and water-soluble metabolites are filtered by the glomeruli. Factors that affect renal excretion is kidney function, age, hydration, and cardiac output. Obviously, that all makes sense. If you've got good kidney function, you're gonna be fine. You're gonna get these drugs out of your body. Age, you know, there's a difference between 24-year-old kidneys and 78-year-old kidneys. No one can argue there. There are some age-related factors. Hydration. The better hydrated you are, you can ask any nephrologist, and they will tell you more hydrated you are, the better your kidney function is going to be. And they'll argue with any cardiologist about that, depending on the situation. And then cardiac output, again, you've got to have a proper pump in order for this to work. If you're not pumping and having good flow down to the kidneys, to your target end organs, this isn't going to work. So all of these things can affect excretion. GI tract excretion, biliary excretion. After being metabolized in the liver, the metabolite is excreted into the bile. Some drugs may then be reabsorbed in the intestine, and that's the enterohepatic cycle, and it's fecal excretion after that. Lung excretion, gases, general anesthetics, and volatile liquids. Rate of excretion is based on respiratory rate and pulmonary blood flow. Sweat, salivary excretion, not very many drugs. Excretion in sweat may be caused by adverse effects such as a rash like dermatitis. Salivary excretion may be the reason patients complain of a taste in their mouth with certain drugs, like a metallic taste. They're excreting some of the drug. Mammary excretion or breast milk. Many drugs are excreted in breast milk. Small molecular weight, lipid soluble. When you're looking to see if a drug is safe or not for your patient, if they are lactating, it is now more of, instead of looking in a book and looking to see, you know, yes, it's safe, no, it's not, or a letter or a number, or these various things we used to look at. Now it's based on relative infant dose, and it has to be less than 10%. So again, relative infant dose, and it usually is, especially antibiotics, less than 10%. Other drugs are simply known to cause harm to the baby, and if they're known to cause harm to the baby, it's an automatic no. Like ACE inhibitors, automatic no. ARBs, automatic no. But there are some drugs that, if acceptable, then their relative infant dose comes into play, and it's less than 10%. Teratogenic, doxycycline, it's an automatic, doxycycline's in pregnancy. But anyhow, that's usually based on the relative infant dose. But anyhow, if you have any questions or there's anything else that I can help you with, please let me know. Thank you.